Hello, I'm presenting on an epidemiological overview of shingles, which is also known as herpes zoster, a viral disease with significant public health implications. My name is Gabrielle Lafser, and I will be presenting today. The health issue at focus is shingles. Shingles are caused by the varicella zoster virus, the same virus that causes chickenpox. After recovery from chickenpox, the virus lies dormant in nerve cells and can later reactivate. Shingles are generally not contagious. Transmission can occur directly if someone with active shingles sores comes into contact with a person who's never had chickenpox or the varicella vaccine. So, in that case, the exposed person would develop chickenpox, not shingles, but can later develop shingles. So, this is why it's not literally transferred person to person. Indirect transmission via airborne particles is minimal and mainly a risk if open sores are present. Shingles affects approximately 1 in 3 people in the United States at some point in their lives, according to the CDC. The risk increases with age, and it is especially prevalent among adults aged 55 and older. Shingles can lead to significant morbidity, primarily due to severe pain that can persist for weeks or even months. This is called postherpetic neuralgia. While death from shingles is rare, it can occur in exceptional cases, usually when secondary bacterial infections develop or in individuals that have weakened immune systems. Shingles is characterized by a rash that typically appears on one side of the body, either the left or the right side, following the nerve path. The rash is often accompanied by symptoms such as itching, tingling, or significant pain, which can begin even before the rash develops. Unlike many infectious diseases, shingles does not have a traditional incubation period, since it results from the reactivation of the varicella zoster virus, which has been dormant in nerve cells since a prior chickenpox infection. Reactivation can occur later in life, especially with age or weakened immunity. Treatment options include antiviral medications such as acyclovir, valacyclovir, and famciclovir, which can shorten the duration of symptoms and reduce complications if started early in the course of the illness. The population most at risk for shingles includes adults that are over 55 and up. Since your risk increases more with age, more than about 99% of Americans that were born before 1980 had chickenpox, which means that the virus is already in their system and can reactivate later in life. People with weakened immune systems are also at a greater risk, including those with medical conditions such as leukemia, lymphoma, or HIV infection, as well individuals taking medications that suppress their immune system, like long-term steroids or drugs given for those who have organ transplants. They're more vulnerable in developing shingles. Risk increases with age. About 50% of new shingle cases are among people aged 55 plus. Generally, women are actually 33% more likely to develop shingles than men, according to a study online. Shingles incidence varies by race and ethnicity. Generally, white Americans have the highest rate at about 7.96 cases per 1,000 persons. Black Americans have lower rates, about 6.2 per 1,000, with older studies showing a lifetime prevalence of 4.5 compared to 16% in white adults. Hispanic and Asian Americans also have a slightly lower rate than white Americans at roughly 6.7 and 6.4 per 1,000 person per year. According to a study by Tsang et al. In 2017, individuals with a family history of herpes zoster are at a significantly higher risk of developing the condition themselves. The study specifically found that having one first-degree relative with a history of shingles actually increased your risk by about 30%, while having two such relatives more than doubled the risk. Additionally, genetic factors play a crucial role in the development of shingles. Inherited immune system variations can influence how the body controls the varicella-zoster virus, and understanding these familial and genetic influences help us identify people that are at higher risks. As far as mental health, not too much affected. Generally, studies link that mental health disorders relate to shingles. Healthcare providers should give a little bit more clear information about shingles to help support timely treatment and address the emotional impact that patients get in their treatment. As far as marital status, not really affected by shingles. Social and environmental conditions often shape those at risk. Those with limited access to vaccination, such as low health literacy and misinformation, are also at greater risk of developing shingles at some point in their life. Environmental factors, particularly like weather and seasonal changes, can influence the occurrence of shingles. Research shows that outpatient visits for herpes zoster tend to follow seasonal patterns, with higher incidence during certain times of the year. Temperature and other meteorological conditions may play a role in triggering these outbreaks. When looking at disparities, shingles vaccination rates are not uniform across populations. Minority and rural communities tend to have lower vaccination coverage, while adults with health insurance or regular primary care physician are more likely to get vaccinated. There are no routine screening tests necessary for shingles, but there are two vaccines. The varicella vaccine, which is given to children ages 12 to 15 months of age, with a second dose given at age 4 to 6 years old to ensure that long-term immunity against chickenpox. While vaccination reduces the risk of chickenpox, it does not completely prevent shingles later in life. Shingles vaccines, called Shingrix, are recommended for adults 50 and older to help further reduce the risk of shingles, even if they received the varicella vaccine as a child. As people get older, their cellular immunity declines, which can trigger the reactivation of the varicella-zoster virus and can lead to shingles. Stress and chronic illnesses act as additional triggers and can further weaken the immune system and increase the risk of developing this disease. Recent studies suggest that shingles may increase the long-term risk of memory loss and confusion by about 20%. However, the exact mechanisms remain unclear, and more research is needed to understand whether shingles directly contributes to cognitive decline and how vaccination might reduce this risk. Also, among healthcare workers, shingles vaccination is hindered by perception issues and a lack of education. Some may underestimate the importance of the vaccine or be unaware of who should receive it, highlighting the need for targeted training and awareness programs in communities, specifically those lower income rural communities. Shingles vaccination is recommended for all adults age 55 and older, including those that are uninsured. Strengthening education for healthcare providers and the public can increase awareness of this disease and the benefits of vaccination. Additionally, addressing barriers such as cost, access, and institutional support is critical to improving vaccination uptake for shingles. Future research on shingles should explore the long-term effectiveness of the Shingrix vaccine to ensure lasting protection. Research should also be explored on the role of genetic predisposition in increasing susceptibility and understanding and addressing barriers to vaccinations to improve uptake, especially in those underserved populations. It should also investigate the potential long-term cognitive effects of shingles to better understand its impact on brain health. National vaccination campaigns should focus on making the Shingrix vaccine widely available at places such as primary care offices, pharmacies, and community centers. To reduce barriers, partnerships with insurance companies and government programs can help offer the vaccine at free or low cost, ensuring better access for all eligible adults. Here are my references. Thank you so much for watching my presentation, and I hope you enjoyed it.